in order to do true co-design, you don't know what the outcome is going to be. We needed to recruit coordinators that needed to be the right people. This is a prototype project. The idea, we had planned it from the beginning to be a spread and scale project, but of course we always need to prototype it in the beginning. And in order to do that, you really need to make sure that you've got the right people. So the interviewing and recruitment process for the right people, for the coordinators, was essential. And it took a while. We were really fortunate in being one of the winners of the 2019 Q Exchange. We were absolutely delighted. It provided us with £30,000. And we actually took a punt, because when we submitted our business case, our financial workings out to Q, it asked several questions. How are you going to use the money? What are you going to use it on? But we were very, very clear that in order to do true co-design, you don't know what the outcome is going to be. So we couldn't say, we're going to run this event and then we're going to do X, Y, and Z. So we were very clear with the Q Exchange that we'll need some money in order to run the event. But from that, depending on what those people who are co-designing it with us, and we had over 135 people with lived experience, we had something like 30, 35 clinicians during the day. If we thought that we knew what we were going to do before we ran the event, and therefore stipulated this in our business case, that wouldn't be true co-design. We would just be continuing to do what the system always does, which is thinks it knows best. We started our project off with the knowledge that we wanted to design for scale. It's all very well developing a prototype and a pilot, for it to work in one place. But if we want to help transform the NHS, we need to identify those things that work, codify which elements of those things that work, and be able to enable, share learning, support others to be able to scale and spread the ideas, the interventions, the innovations, if you like. So we were very, very clear at the beginning that in order to really design for scale, we needed to co-design this with the people most proximal to the issue. So those people with lived experience who were experiencing, at the time, it started off with outpatients follow-up. So we looked at, and we sought the inputs and co-design of people with both high levels and low levels of activation, which is knowledge, skills, confidence, and motivation to self-care. And it wasn't necessarily around a single condition; it was around their whole health conditions. Because again, we know that we've got more people in our population who are living with 2 or more long-term conditions than they are with one single health condition. So it was important for us to co-design at the beginning with those people most proximal to the issue. And to be honest with you, we didn't anticipate that this was the project that we were going to be running with back in 2019, which is a good thing. We were very open-minded about it, but this was something that individuals themselves felt that would help them. And some of them also felt that they wanted to do this. So we co-designed with those most proximal to the issue, and we continue to do that. We're using quality improvement methodology. We have set an aim. We understand what metrics we're using. It's both qualitative and quantitative. We know what we're looking for when we know if it's successful or not. We're continuously iterating the model. So, for instance, our first cohort of coaches came through, and in the NHS, we're quite used to running 2.5 hour training sessions online. And it doesn't seem to be a problem. However, when we were working with people with lived experience, what we were finding is about 40 minutes to an hour in, um, was probably enough. So we've started off thinking about all of our outpatient clinics, but we're also thinking about those people who are perhaps in primary care, in community care. So this intervention doesn't just need to, or isn't designed just to support outpatients, although that's where it came from. This can support people wherever they are and whatever stages of their self-management journey, if you like. I applied for the NHS Clinical Entrepreneur Programme in 2020, and was successful. And I applied on the basis of this particular project. It has given me a platform which to talk about the Health Connect coaching, but it's also given me a lot more ideas and a lot more skills and confidence and knowledge as to how I can design and spread and scale and share future innovations, because innovators don't just stop at one idea. What they constantly have different ideas. My strongest advice would be, in order for us to transform the NHS, to add quality and value through the lens of the customer, we need to co-design it with those people closest to the issue, those people most proximal to the issue, and not to be frightened of that. Choose the people that you're working with. There's not just people who are your tame patients. Take time, be brave, and co-design with people closest to the issue.